And I would like to welcome all to our seminar today, another IEO seminar. My name is Nicoletta Batini. I'm the IEO lead evaluator, and this seminar is being recorded. It's about today the risk of pandemics and the role of policy. So the recent COVID-19 pandemic, which started in 2020, of course, as we all know, caused a large loss of human lives, a loss that is comparable to, a really bad flu season. Certainly looking historically back, not the 1918 type of pandemic, but still, considerable loss of human lives. And remarkably, the largest global economic crisis in more than a century. And with the benefit of hindsight and a lot of data now available, there's been efforts to measure the effectiveness of the response with which many governments around the world have reacted to this pandemic. And at the same time, scientists around the world are trying to figure out, what caused the pandemic and how we can reduce the risk of a new pandemic. There's a lot of talk about the next pandemic. It's almost as if it's a given. But truth is that there are many ways in which we can, of course, avoid it to happen again, or at least minimize the risks for it to happen again. We know these kind of pandemics happen like once in a century, so certainly we shouldn't be expecting one, every 2 years. And what I've done to explore these issues, which of course are very much related to macroeconomics, because the impact of this event has really wreak havoc upon a lot of what we had, the prosperity that had been built in the global economy in the past years, especially after the GFC. But also these are really tremendous risks to the economic outlook. So great interest for the IMF. So I've invited two academics who have, strived to understand and study these issues. And they plan to talk about, reform strategies to make pandemics more unlikely in the future, but also to really examine the response of governments in terms of economic policies and non-pharmaceutical intervention, see what, could have been done different to minimize the impact on the economies. So let me introduce them to you. They need no introduction, but I'll go through them because they're very famous in their own right. First of all, we have Professor Robert Topel, who is Isidore Brown and Gladys Brown Distinguished Service Professor of Economics at Chicago Booth. He conducts research on many areas of economics, including labor economics, industrial organization, antitrust, health economics, energy economics, national security economics, economic growth, and public policy. Professor Topel is the co-director of the Energy Policy Institute at Chicago. He and fellow Chicago Booth faculty member Kevin Murphy won the 2007 Kenneth Arrow Award for the best research paper in health economics. And Bob is the author of several books and has served as editor of the Journal of Political Economy. So there you have, and he has worked, of course, extensively on examining the economics of this pandemic and the response of government. And then we have Marc Lipsitch, who's professor in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health, where he's the director of the Center for Communicable Disease Dynamics. Marc has worked on modeling the transmission of COVID-19 and oversees research at Harvard engaged in improving the mathematical modeling of infectious disease, as well as how such information is effectively communicated to policymakers and their constituents. So this is really very important stuff for the IMF in many respects. In 2009, Marc served as a member of the President's Council of Advisors on Science and Technology with the H1N1 flu pandemic working group. And in 2014, Marc co-founded the Cambridge Working Group, whose efforts helped to initiate a pause in US government funding for research involving the creation of potential pandemic pathogens. He has written extensively on aspects of science policy in relation to such studies. And in 2021, he was named Director for Science at CDC's new Center for Forecasting and Outbreak Analytics, where he remains a senior advisor. Views expressed in this seminar by Marc are in his personal and academic capacity. So without further ado, I would like to start with Marc. Marc has a presentation where he's gonna explain to us, what can be done and what he sees are the risks, of new pandemics and why structural forms can be put in place that minimize these risks. And then we'll move to Babu to discuss, some of the nitty gritty of the economic policy response. Marc, I leave the floor to you. I think I have to share it for you. So let me do that. And then you'll tell me next slide as we go through. So this is that. Let me know if you can see it. I'm trying to put a reading view.
Yep.
There it is.
Great.
Okay.
Thank you, Nicoletta. Thanks for the opportunity to be here. As Nicoletta said, I'm interested in a number of different topics around pandemic prevention and response, but I chose to focus today on the issue of prevention, and specifically on the issue of regulation of a very small category, but potentially dangerous category of research that risks an accidental pandemic. Could I have the first slide, please?
Gotcha. Sorry, is that the first one?
Yeah.
Okay.
So what I'll try to tell you today is five main points. First, that laboratory-associated infections occur with surprising frequency, including in the most respected high containment laboratories. Secondly, that for the vast majority of virology and an even higher proportion of biology, the risks of these infections are simply to the lab workers in the sphere of occupational health, which will not be my concern. What I will be focused on is the specific types of research that involve pathogens with virulence and the possibility of human-to-human transmission, where the risk extends beyond the laboratory to the public, and potentially to the globe in the case of really transmissible novel pathogens. I'll make the argument that the public health benefits of these studies are limited and can typically be accomplished with safer approaches, and suggest that we need to improve oversight of this limited class of studies to reduce the risk of an accidental pandemic. And this is really an ongoing debate that has become reactivated in the light of the COVID pandemic and the demonstration of what a pandemic can cause in terms of destruction. It was a global topic of conversation, intense conversation before the pandemic. It paused very much during the pandemic and has now come back to the agenda. And I want to try to make a case for why it should be moved ahead. Next slide, please. I'm not making this argument because I think that the current pandemic originated in a lab. I think that is a possibility, but that is not a part of my argument, and it's really a separate question. And secondly, many of you will have heard the term gain of function research, which is the type of research that I'll be talking about, but is a much broader category than the specific aspects that I'm going to refer to. So the term gain of function broadly encompasses safe and useful research that is not really relevant to biosafety at the global scale. My claims are going to be limited to research that could start an accidental pandemic, some of which may in fact be of sufficient public health value to be worth the risk that we should evaluate claims of benefit rigorously. Next slide, please. So I do want to define a few terms because these terms get rapidly slippery, and it's important to know what we are and aren't referring to. So the term gain of function, which is often used in its broadest sense, really is a very common technique in biology where we modify organisms to acquire a new function, which might be drug resistance, it might be escape from immunity, it might be the ability to produce a new sugar or a new protein. It's done all the time. It's almost always safe and it or poses a small occupational risk and almost never needs more scrutiny. The category of research that I want to talk about is what's known as gain of function research of concern, which is a small category that uses or risks creating biological entities that could cause a pandemic. And it's sometimes referred to as enhanced potential pandemic pathogen research, which is another word for the thing that is produced in this kind of work. Next slide, please. So to make my first 2 points, next slide, please. Many of you may have seen this recent book that came out about 3 weeks ago from Alison Young, a journalist in the United States, which lists a remarkable number of laboratory incidents and actual accidents where humans were infected that are, and makes the point that they are common and rarely transparently reported. I won't read the list, but it is a long and remarkable list. Next slide, please. And some of those accidents lead to infections, and some of those infections lead to deaths. The absolute number of infections and deaths is relatively small in some sense, and perhaps a tolerable price to pay for the type of research, for the benefits that we get from this research. But what I want to focus on again is those examples where there's been infections of humans with an agent that has a potential for significant spread. And that includes the likely reemergence of the 1977 H1N1 flu, which was present up through the pandemic of 2009 and infecting and killing millions of people around the globe in most years. That event is almost certainly came from a freezer, but by what exact mechanism is unknown. There were infections of laboratory workers with SARS-1 in 2003 in 2 countries, and a small outbreak of SARS-1 in 2004, again from laboratory accidents in Beijing. The British outbreak of foot and mouth disease in cattle had major agricultural consequences and came from a laboratory leak. And there were 10,000 individuals infected recently in China from an outbreak from a laboratory producing vaccines. So this is not an inconsequential type of risk. Next slide, please. So I've just said 2 seemingly contradictory things, that there is this category of research that poses a potentially huge risk, and also that the number of deaths and consequences of experiments to date, of laboratory infections to date, have been relatively tolerable, arguably. And there's a very clear reason for that, which is that although they are serious, most of the releases to date pose little risk to the globe, either because the pathogens under study are not transmissible, like anthrax, which you can only catch from the environment, not from another person, or are poorly transmissible, like Ebola, which can be contained readily with enough resources in the places where it's under study. Alternatively, other pathogens are already locally common, so we have immunity to them and they don't cause further spread, significant further spread. Next slide, please. So what is the specific type of research that I want to focus on? Next slide, please. It is research that poses population level risks, which is research with potential pandemic pathogens and versions of them that have been enhanced. And they have characteristics that are important in combination. of being readily transmissible in humans or modified to be so, virulent, but not necessarily highly so, because we've seen that even a modestly lethal pathogen like SARS-CoV-2 can cause dramatic damage, and posing a public health risk that is significant in its increase over the background from naturally occurring strains. That would include, for example, smallpox, work with smallpox, work with enhanced avian influenza strains designed to have human transmissibility, as has been done, and I'll describe in a second. Original SARS is now another potentially pandemic pathogen, or extinct flu strains as some examples. Next slide, please. So the modern debate over this topic really began with work in which two laboratories, one in the Netherlands and one in Wisconsin, United States, took an avian influenza virus, introduced genetic changes in that virus that were expected to enhance the ability to transmit in mammals, and then trained it through a directed evolution process to acquire the ability to transmit from one ferret to another, ferrets being an excellent model system for humans. Those viruses at various stages were taken out, sequenced and studied, and then that process repeated to ensure very high transmissibility between ferrets, which was accomplished in both studies. Next slide, please. So why do we, why do I advocate that we focus special attention on these kinds of rare but potentially hazardous studies? It's really that in this small subset of studies, there are externalities that are not captured by the general efforts that occur to people who really have no knowledge and no ability to make decisions or prevent the experiments from happening. It is a tiny fraction, under 10% of the budget of the Institute of Allergy and Infectious Diseases in the United States, that causes these public health externalities. And the argument is simply that while we accept a certain level of accidents for the sake of scientific progress, when the risk is to ones and twos of individuals, the same rate of laboratory-acquired infections may be unacceptable given a larger number of individuals infected. Next slide, thanks. So here are some illustrative calculations that were published in 2014. Whoops.
Sorry.
They were published in 2014 with Tom Inglesby to give you a sense of why this seems concerning. So if you look at all of the biosafety level 3 laboratories in the United States and their work with a particular class of agents of concern, there were at least 4 laboratory acquired accidents over 2,000 laboratory years of work, resulting in an estimate of around 0.2% risk of a laboratory infection per laboratory year of work in a BSL-3 laboratory. In the intramural laboratories at the National Institute of Allergy and Infectious Diseases in the United States, there were 3 such accidents over about 317 worker years. So that's actually a higher rate per worker year, given that most laboratories have multiple workers. Next slide. But obviously, if you are working with a non-transmissible agent, then those cannot cause pandemics. And even if you're working with an enhanced agent that has human-to-human transmissibility and is novel, there is not a certainty that a laboratory infection would cause a large-scale outbreak. So in various ways, we estimate that risk is somewhere between 5 and 60%. If you're working with a contagious and novel influenza strain, and multiplying those two numbers together, you get somewhere in the range of 1 in 1,000 to 1 in 10,000 risk per per BSL-3 laboratory year working on a contagious novel flu. So very unlikely to happen, but with high consequence. And next slide, the consequences are, if you take a SARS-CoV-2 like pandemic, something along the range of 20 million global deaths, and a highly virulent pandemic of avian influenza could be in the super above 1 billion fatalities if it was allowed to spread. So multiplying once again, and just focusing on the low end, because I think the high end would hopefully never happen, you get something on the order of thousands of expected fatalities per laboratory year of work on this kind of pathogen. And I go through these calculations, next slide, please, not because I think any of these numbers are particularly hard. When we wrote this paper, we tried always to pick low end numbers, but they have been debated. Next click, please. The PI of some of these studies estimated that we were off by a very large factor of many orders of magnitude, and we responded. Next click, please. So I think there is room to improve these numbers. I don't think that they are unduly high, but I think there is room for discussion. But nobody would actually advocate an experiment that in expectation causes 2,000 fatalities or more. And so I think the question is, are they even of the right order of magnitude or within a few orders of magnitude before we think they're a good idea to perform? Next slide, please. And recall that we do not allow scientists to perform experiments that cause undue stigma to tens of individuals, thanks to human subjects protection, that involve chimpanzees, that cause unnecessary suffering to tens of animals, that place tens of consenting volunteers at a mortality risk of 1 in 1,000 in the United States, at least, where we did not begin any human challenge studies of SARS-CoV-2, although some such studies were done in the United Kingdom, or those that involve smallpox virus outside of 2 labs in the world. So we do limit science when we think that it's got potential for destruction. Next slide, please. So presumably, if people have been doing this kind of work and there are risks, there must be some benefits to it. And there are some benefits. So I next want to argue that these public health benefits are limited, but more importantly, can be accomplished with safer approaches. Next. So Alison Galvani at Yale and I put together this table that suggests various ways, various scientific approaches that can help us to learn about the nature of influenza, which was the type of study that was most prominent in the previous rounds of discussion. So potential pandemic pathogen creation is risky, but also very costly, and therefore has low throughput and generalizability. So if we think about comparative approaches, what we lose in the precise scientific question, we gain something back in the ability to generalize, to do multiple different strains of virus, and to learn the science in a much more general way, because we can do more for the same cost. Next slide, please. So what Tom Inglesby and I proposed in the midst of this debate was that we should assess these benefits first in the sense of what do these studies do to promote public health, as opposed to their purely scientific benefit. And secondly, that we should assess them relative to an equal expenditure portfolio of alternatives. And it's nice to be talking to economists who perhaps think that way more naturally than people who review grants, science grants, for part of our living, where it's always, do we do this or do we not do this? It's never the question before you is never, how can we make this better? It's always, yes or no to a particular thing. But as economists, you'll understand that in the end, there is a budget. It funds science. And the real question is not, should we do a potentially dangerous experiment, but should we do it in preference to alternatives? Um, and finally, that the benefits should be specific and subject to scrutiny. We should scrutinize these benefits in a way that we don't typically scrutinize the first paragraph of a grant proposal, where you say all the great things that are going to come from the research, hopefully, and we don't usually take a fine-tooth comb to that first paragraph. And we shouldn't in general, because usually we don't really know what science is going to bring us, but we know that doing a lot of it will bring us a lot of benefits. And we're spending money rather than putting lives at risk. Next slide. So I have a few examples, and I think I'll skip some of these to save a little bit of time so that we have more time for discussion. But just as an example, the experiments that were performed that I described earlier to enhance H5N1 influenza viruses that could transmit in birds, to teach them to transmit in ferrets and see how they became mammalian transmissible. Everything that was identified as a potential marker of human or mammalian transmissibility was a mutation that had been seen before, and this table and this paper lay out where those changes had been found before. And importantly, there are major limits to how much you can generalize from the study of a single virus and its ability to transmit in mammals, because of the phenomenon that when you change another part of the virus, the effect of a single mutation may change or even reverse in direction. So these are not simple to interpret. Next slide, please. I'll skip that and skip that for time reasons. So I want to close by arguing for the value of improved oversight of this limited class of studies to reduce the risk of an accidental pandemic. Next slide. To give you a little bit of the history of this discussion, the discussion really began in 2001 when Australian researchers produced a version of mousepox that could evade vaccines. Nobody cares about mousepox particularly, but the concern was that this was a blueprint for malevolent actors to do the same thing in smallpox, which would, of course, undermine the major way that we control smallpox. Subsequent events included accidental infections from SARS and from foot and mouth, as well as the reconstruction in 2005, perhaps the first modern potential pandemic pathogen study, the reconstruction of the H1N1 flu from 1918. But then the real controversy and modern controversy began in 2011 with papers that were eventually published about the enhancement of H5N1 avian flu which killed roughly half the humans that it infected when it spilled over. And these were enhancements to make it more transmissible in ferrets as a means of understanding its transmission in people, and therefore potentially of making a human transmissible H5N1. Up till that point, much of the debate had been whether we were giving hints to bioterrorists rather than about biosafety and accident concerns. And when we formed the Cambridge Working Group in 2014, we tried to shift the focus not away from biosecurity and malevolent actors, but also to encompass biosafety concerns. Next slide. Much of the recent history has occurred in the U.S. because because of the funding pause that the U.S. government put in place on research that enhances pathogenicity or droplet spread. That lasted from 2014 to 2017, when a policy was put in place to try to regulate this kind of work. Somewhat inadequate policy, as I'll mention in a minute, but a policy nonetheless. And then all the discussion stopped when the COVID pandemic began, and resumed in late 2022, late last year, and has come to a sort of next stage with the release of a final report from a board called the National Science Advisory Board on Biosecurity in the United States, recommending changes to the oversight framework that was issued in 2017. Next slide. And I think it's worth reading this this excerpt from that final report, because it is a pretty good attempt to try to encompass what is important about what are the important types of research to regulate. And the phrasing is that that it involves the construction of potential pandemic pathogens that are likely moderately or highly transmissible and capable of wide and uncontrollable spread in human populations, and or likely moderately or highly virulent, and in addition likely to pose a threat to public health. So that's where the novelty comes in, because transmissibility of an agent we already have is not as big a deal as an agent to which we all lack immunity. I have some quibbles with that, which I'm not going to mention, but I think it's a step in the right direction. It has not yet been adopted. In the meanwhile, significant numbers of experiments have been, in my view, slipping through the cracks in this regulation, and that includes the enhancement of bat coronaviruses in Wuhan. Not saying that that led to a pandemic. I'm just saying that that was a risky type of research to do. There were proposed recombination experiments to combine the more transmissible and the more virulent forms of monkeypox at the National Institute of Allergy and Infectious Diseases. The House of Representatives wrote a letter to the NIH asking why they were doing such work. It was not answered for 4 months, and then eventually they said they would not be performing that work. And another example is the construction of a measles virus that escapes vaccine immunity, designed for to be a cancer treatment. My view is not that all of this work should have been stopped or not done, but that it needed to have very public and very specific scrutiny for why it needed to be done, what safer alternatives existed, and what the public health benefits would be to offset the risk. Next slide. Next slide, please. So the US, I think, has one of the most advanced, at least regulatory processes. It's not a legal approach, it's a regulatory approach in the United States. But important gaps include that the approach at the moment includes only research that is sponsored by the Department of Health and Human Services. So not other parts of the US government, not other governments, and not privately funded. It doesn't keep up with the changing aims of science as scientists change their plans for very appropriate reasons. It doesn't actually get all of the studies that need to get into the system because the funder has an incentive to keep things out, and the funder is the regulator. And there are some, for now, the policy only applies to highly virulent, highly transmissible strains, when in fact we've seen from COVID-19 that modestly virulent but highly transmissible viruses can cause dramatic havoc. Next slide, please. So the view then that I want to argue for is that all of this research that is potentially creating such strains should be reviewed, but then some should probably proceed, and that we just need to have a risk and benefit weighing process. And I think there are some principles, some scientific and public health principles that govern that, and I'll skip that. Happy to talk about them during the discussion. Next slide. And let's skip through this slide too. Just to repeat that we have lots of other reasons why we constrain research. I think we like to think that, or some people like to think that constraints on research impinge on our academic freedom. But as just noted, we accept limits to our academic and scientific freedom when there are important interests at stake. There's also the notion that science has enormous and unpredictable benefits, but I think that this idea of weighing against alternative science helps to address that. There are also cognitive biases that are at play. We often have the urge to act against a threat even when it's unwise to do so. And if you haven't read this classic article in Medical Decision Making, it's illustrative of how we sometimes reason not very rationally about the desire to take action. We'll skip the next slide too. And the next. Sorry, this was a little longer than I planned. I think that we have at the moment the luxury of thinking about experiments with known and named pathogens that are typically expensive and government funded and often don't have a profit motive. All of that could change and is beginning to change as the private sector gets interested and as things get cheaper to do. So I think the need to figure out a sensible policy now it is partly because we need to solve the easy problems in order to have a hope of solving the hard ones. Next. I think journals can play a critical role in the same way that they enforce prohibitions on violating the human rights in research. Next slide. And finally, I think I've been focused a little bit on the United States because we have an active process in the United States right now to discuss this. But I think that on one hand, local action really helps. I think certain countries that are leaders in research will set a global example. But also we need wisdom from around the globe to solve it. There are really thoughtful people in many countries thinking about this, in Thailand, in China, in Germany, and many other places. And because funding crosses borders, there's a need to make a global effort. On the other hand, each country that takes action makes a reduction in the risk, and I don't think we should wait for perfection. And the last slide. I think COVID-19 has brought us all the realization, as we'll hear in the next talk, about the potential destruction of a pandemic. Sorry, this was from a previous meeting, but I think there is a reasonable middle that we really need to take a lead in shaping policy that navigates between the certain scientists saying leave us alone, we'll regulate ourselves, and potentially heavy-handed regulation coming from legislators, and that we just need to find a way to weigh risk and benefits even when we have the challenges of low probability, high consequence risks. Thank you. I'll stop there.
Thank you, Mark. That was amazing. I think it really clarified a lot of things for people that maybe are not familiar with this type of research. And I think when you were talking last slide, I was thinking about, the great financial crisis and the regulatory ecosystem for banks who, kept telling us when we go in meetings, oh, we're going to regulate ourselves. And then what might happen if you don't keep an eye on what's going on. I'm going to pass the baton to Bob. Let me share your slides, Bob, just a second. Let me find them. So let me first close Marc's, and so that I don't mess up. Okay. I need to open this. Just give me a second because I'm not ready. Have this on and this be that. Yeah. Can you guys see this?
There it is.
Okay, Bob, the floor is yours. I keep my mic on unmuted because I can't do everything at once, so I can talk to you in case. Please tell me when you need the next slide.
Okay, I'm going to talk about some things I did with my colleagues Kevin Murphy and Casey Mulligan before, in the earliest stages of the pandemic. So you might view what I'm going to talk about as relative to Marc's. Well, what happens when one of these critters does get out and propagates the way the COVID-19 virus did. So next slide. So I'm going to look back at our 2020 look forward. And I, like Marc, I probably have too many slides, but I'll try to go through them as fast as I can. So early in the pandemic, we analyzed information challenges and policy alternatives. And the pandemic was then a unique event about which little was known, but if we look forward from today, it's unlikely to be unique in the future. But despite these mitigation efforts, the CDC estimates that we suffered about 1.8 million excess deaths, of which about 1.2 million were directly attributed on death certificates to COVID. And that was really highly concentrated among the elderly. 82% of those deaths were the people over age 60, and over half of those were people over age 75. Next slide, please. So what are the costs of the pandemic? They come in the sort of three main categories. One is the thing that everybody's familiar with is loss of life due to the direct effects of the disease and also indirect effects that affected people's lives or suicides and so on. The next category is the economic costs, and this will be familiar to much of the audience, I guess, of reduced activity. But what people don't focus on as much is that those costs carry over into the future, and they include the costs generated by poor policies. And the third category, which is related to the second, is the loss of human capital from reduced activity for people who are in the labor market or jobs that are destroyed, and the education of the young. And those are permanent effects on an entire generation. The direct resource costs of medical care in comparison to those three things are likely to be medical care, investments in capacity, so on, are likely to be quite small in comparison to those costs. I'm going to put some numbers on them in a little bit. And it's important for us to recognize that both current and long-term costs, many of which are policy related. Next slide, please. So the CDC produces estimates of mortality that are directly attributed to COVID, and excess deaths that are relative to a benchmark of mortality by age and other demographics for 2015 to 19. And I've graphed them both on a weekly basis here. From the beginning of the pandemic, I started January of 2020. The red line is excess deaths. And what you can clearly see is that the way the CDC is attributing these, the actual attribution of COVID-related deaths is much lower than the excess deaths estimates, especially in some periods. It tracks well at the end of 2020, but really poorly in 2022. The total amount of COVID attributed deaths is about 1.2 million, but the excess deaths they estimate are 1.8 million. And I'm not going to vouch for their estimate of of excess deaths. Like I said, it's just relative to a benchmark of mortality rates at various characteristics in the 2015 to 19 period before the pandemic occurred. Go ahead, please. So here's the way the COVID deaths and excess deaths break out by age. So more than half, of all excess deaths occurred among people age 75 and above. 80% of all such deaths, it's age 60 plus. That undercount, if you view it as an undercount of the effects of the pandemic, is often large. Including among the young. I didn't include in this graph because it just wouldn't fit with too many age categories, all the way over to 0 to 14. But among 0 to 14, the excess mortality was negative. That death rates were lower in that category than than pre-pandemic. And I don't know why that is. It might be because kids didn't get to go out and do all the things that they would have done otherwise, and that reduced mortality. And they were unlikely to be affected by it very much, as you can see by the pandemic itself. They were much less likely to become severely ill if they were infected. Go ahead, please. Now, most of the people here are economists. So, but I want to bring in the concept of the value of a statistical life, which is what people are willing to pay to avoid a risk that would claim one life in a large population. And the Environmental Protection Agency uses a value per life saved for cost-benefit analyses of policy interventions of about $11 million. So let's take that as given. If you don't like that estimate, you think it should be higher, go ahead and make it higher. If you think it should be lower, go ahead and make it lower. But that's basically what that government agency and other government agencies do. These estimates are put together by an interagency group of economists and statisticians that upgrade the estimates from time to time. My colleague Kevin Murphy and I, in our 2006 paper, allocated that value over the life cycle. So technically speaking, the value of a statistical life at any age is the present value of remaining life years at that age. If we use that $11 million, we have to take into account that they use per life saved. We really have to take into account that it's going to vary by age for two reasons. It's going to decline for two reasons. One is that life years at older ages are less valuable to most people than life years at earlier ages. So if I asked you, would you rather have an additional life year at age 85 or 90, or would you rather have it at age 35? Most people will grab for 35. And that tells you that willingness to pay for a life year is higher at age 35 than at age 90. So we don't have to, you can admire the technical aspects at your leisure, but we came up with a profile that looks like the one in the graph. The other reason is that because it's a present value of remaining life years, people have fewer remaining life years towards the end of life than they have at younger ages. So that's why the profile looks like the one there. And that kind of has important implications. Next slide, please. For the way we think of the trade-offs that occurred during this pandemic, or others assuming that they have the same, a similar age profile. So I graphed here on the right axis excess deaths by age category, and you can see that the excess deaths they're measured in thousands. For very young ages were really low. In fact, 10 there refers actually to 0 to 14. It was negative in that category, but it was sharply higher among the old. And the trade-off is that the lives saved at young ages would be very valuable because that's when the value of statistical life is high, and less valuable at older ages where actually mortality was quite high. Nevertheless, the losses, despite that pattern of value, the losses were much higher. Next slide, please. Among the old. So if in this graph, I just give you the value of lives lost by age group from 2020 to the end of March in 2023. And the cumulative value of lives lost over all ages comes out to about 6.2 trillion. To put that in context, that's about 30% of annual US GDP. And it's more than federal government spending, which comes in around a little bit under 6 trillion. So despite the declining value of a statistical life with age, it's strongly related to age, except among the very oldest, where the values are the smallest. That's a consequence of the weighting. But as it turns out, it looks like the young were impacted, but the young were not spared. Next slide, please. The loss of human capital during the pandemic may exceed the mortality costs themselves, using the metrics that I used on the previous slides. So the kids were not at serious risk, and we knew that very early on in the pandemic. It was a huge mistake for us to keep schools closed or remote. Rick Hanishek, an education economist at Stanford, estimates that K through 12 students lost about 0.7 years of effective education. And that's a permanent effect based on other experiments where education has been interrupted. It's equivalent to about, given a typical rate of return per year of schooling, a 5.7% reduction in lifetime earnings. Using estimates of what typical household or individual income comes out to be, that's about $140,000 reduction in the lifetime wealth per student, which is a big number. Now we have 55 million K through 12 students, including both public and private. And if they all suffer that, that's about a loss during the pandemic of 7 trillion in the present value of the value of current and future human capital, and that ignores the college students. So that 7 trillion, if looking back to the previous slide, we don't have to go there, is comparable to the mortality costs that were estimated, but it's gotten much less prominent discussion than the mortality costs themselves. Now you have to add on to that, I haven't done so, but you have to think about it, the loss of labor market experience. Because time in the labor market raises productivity, human capital, earnings. So it accumulates with work experience. The most rapid growth is up to about age 35. So shutting down sacrificed that experience accumulation for a generation of young workers. And if we backed out numbers for that, I think they'd be comparable to what I was talking about just a minute ago. And then there are other losses of human physical capital. With lower human capital, there's going to be lower economic growth in the future because ideas are less likely to propagate and so on. So the young really weren't spared from this, and the costs of the economic costs, just in terms of human capital, is comparable in magnitude to the type of the losses that we've suffered from increased mortality. Next slide, please. So back in 2020, we discussed strategies for tackling pandemics, and recently we looked back at it and said, you guys can judge for yourselves. But we thought, that wasn't bad given where we were in April of 2020, March and April when we wrote stuff. So there were 3 primary strategies that were on the table at the time. One is just reductions in activity and which takes the form of reduced social distancing. And that reduces the potential to spread the disease. So when those things are applied broadly, we called it large-scale social distancing. Those restrictions are very costly. because they're very poorly targeted. They're not targeted where an intervention would have the highest marginal product. But they can be effective at reducing and maybe more importantly, delaying the spread of the disease for a limited time. But they're not viable long-run strategies. At the beginning of the pandemic, one of my colleagues who has a penchant for hyperbole and getting clicks said that we should be prepared to close down the economy for 3 years, which was just absurd. First of all, you want to think about, well, how would you eat? But, in the absence of something like a vaccine that would come along, limiting infections in that way for a period of time isn't going to limit the long-run impact of the virus, because they're going to come in when you reopen. So as a subset of these large-scale social distancing, you have more focused social distancing policies that are targeted at the most vulnerable, and those make a lot of sense. That's the kind of thing we tried to do with the elderly, but as you saw before, it wasn't entirely successful. The second type of strategy are targeted policies that we refer to as screen, test, trace, and quarantine. So that those where you quarantine both those who are found to be infected and those with whom the infected have had some discovered social interaction. So it can buy time, or it can even keep an infection contained long term, which is related to policies that were pursued during Ebola. So, and then the third thing is efforts to find improved treatments, a cure for, or the thing that was most prominent during the pandemic was a vaccine. And those complement the above strategies by reducing the amount of time that containment needs to be applied. So buying time is going to be is a really important strategy, or turned out to be a really important strategy in this pandemic. Next, please. Next one. Right. Okay.
Is this one?
I'm. What comes before that one?
Okay.
Okay.
Sorry.
It's okay.
This one?
Yeah, that'll work.
This one? Yeah.
So this slide compares large-scale social distancing and the alternative targeted of testing, targeting, and quarantine. So large-scale social distancing, you can think of it as an economist as a fixed cost technology. The cost of implementing it is largely independent of the level of infection, whereas STTQ has a significant variable component. It costs more when there are a lot of infections, less than when there are very few infections. So it's kind of high fixed cost, perhaps lower marginal cost. So large-scale social distancing is going to have a comparative advantage when infection rates are really high, whereas STTQ has an advantage when infection rates are comparatively low. That high cost of large-scale social distancing makes it unattractive as a long-term application, and that's kind of my point when I talked about my colleagues' comment about closing down the economy for 3 years. Whereas STTQ can be applied long-term if screening costs are relatively low. The TTQ part of costs are proportional to the infected population, which it can be low for a contained pandemic and will be low at the beginning of a pandemic. Go on, please. So our objectives for limiting the loss of life were to buy time to find a cure or an effective treatment. Limit the speed of the infection in order to limit stress on the healthcare system. That reduces mortality rates even among those infected because they're more likely to be able to access treatment. Control the death mortality for a given level of infection by selectively isolating individuals. The elderly and those with comorbidities are the most prominent examples. And then we try to strategically flatten the curve while awaiting population immunity, either natural or via vaccine. So, and then the last thing is just to contain the virus long term. Go on, please. So economic costs. For COVID, I made the case earlier, and I think people agree, the cost of the disease vary greatly across individuals. For the young, the health costs were very low on average, but they're very high for others. So that degree of heterogeneity also applies to activities that vary greatly in the impact they have on the spread of the disease. Policies that leverage individual information are likely to be really useful. And that's because people engage in self-protection. They're self-interested when they are aware of their own risks. So we want to have policies that kind of leverage that incentive, if you will. The other is consider both the current and the future costs and benefits of policy interventions. Strategies that simply postpone a cost a year or two are not going to be of great value unless that postponement makes accessible a vaccine or some other type of treatment. So both the pandemic and our responses are likely to affect our future productivity by reducing current investments in human capital and in physical capital, and by destroying the value of existing human and physical capital. Go on, please. There was a great deal of uncertainty. Had we known that a vaccine was coming in 12 or 18 months, then a strategy of buying time can be very successful, even if delaying on its own would not provide long-run protection from the disease. And it turned out it was. Operation Warp Speed yielded huge benefits because the vaccine came on, I think, a bit earlier than even the most optimistic people back in April when we started talking about April of 2020 when we started talking about this thought possible. But if a vaccine or effective treatment is a long way off, then a strategy of mitigating overall costs that runs its course could be in order. So you're going for population immunity. So a long-term lockdown, however, is not really a viable option, even if you think the vaccine is expected to come fairly quickly. You still have to manage the pandemic. So when we don't know which of these is coming, a strategy that attempts to both slow progression and manage mortality and other costs is the best course. Go on, please. Let's pass over this one in the interest of time. I want to get to a couple of graphs down here. Keep going. Keep going. Keep going, because I want to close it up. One of the main thoughts on reopening that I do want to emphasize, though, in light of those previous estimates of lost human capital, is that at the time we wrote, we really emphasized that we should focus on opening schools. The kids were losing a lot from being out of school, and that would have long-run impacts. And the evidence now ex post is that it really did. And I think it was a mistake to close down education to the extent that we did. Go on, please. Let's go on to just go on. Potential strategies. So containment through an STTQ regime, it's attractive for long-term use aimed at containment. Long-run containment requires maintaining active infections at a low enough level where STTQ has a significant cost advantage. But an LSSD policy might be necessary up front if initial infection rates are really high. In that case, LSSD is cost efficient, where it takes time to develop and implement an STTQ strategy. Go on, please. Buying time for a vaccine was very similar to long-term containment. As with LSSD, it's largely a stopgap measure, so it's best to apply STTQ strategically early. In terms of these propagation models, it limits overall costs. And that reduces both the loss of life and the cost of implementation. Here we go. I wanted to get to these. So we did a couple of simulations, if you will, with a typical disease propagation model. And the idea here is you're going to incur these costs. And as the economists, we want to incur costs or apply resources, if you will, where they have the highest marginal product. So when should we incur costly restrictions? So we modeled here a restriction that a 30-day restriction on social interactions, or all interactions, that reduces transmission by 50% below its but-for level. So we could do it early in the pandemic for 30 days, from days 30 to 59, or later from days 60 to 89. And what the blue curve there shows the later intervention, the infection rate with the later intervention, and the black curve shows the earlier intervention. And you can see that it has a larger impact when it's closer to the time where infection rates are likely to be high. Go on to the next slide, please. This slide shows the evolution of accumulative infections during that exponential growth phase for these two 30-day interventions. And the later intervention, for the type of intervention we did, the earlier intervention is more productive in this case. Go on, please. So the reductions in cumulative infections due to a 30-day policy intervention, we get up over 7% out at 100 days. Now that can be important because it can reduce the overall infection rate, the number of people who are cumulatively infected by the disease. Go on, please. So should you delay the rise in infections or reduce the overall number? The cumulative share of the population that's been infected, that's just a delay. With no infection, you get the gray thing. With intervention at days 30 to 89, you get the blue curve. And though the total infection rate in the absence of the arrival of a vaccine or other treatment is ultimately the same, you end up delaying things which can affect the stress on the healthcare system, and also make the population more take advantage of the arrival of a vaccine should it be on the horizon. Go on, please. So the cumulative share of the population that's been infected with no intervention, it would be the gray curve. With an intervention where you really target it at the days where the disease is most spreading most rapidly, in this case it was 120 to 179, you can have a significant effect on the long run infection rate before you reach population immunity. Go on, please. So limiting the long run cost of a pandemic. The case we made is that you want to strategically apply a large scale social distancing policy to limit the excess of the long-term cumulative number. Limit the economic cost and loss of life by achieving immunity at the lowest possible cost, and limit the loss of life by avoiding overloading the healthcare system. That's the flattening the curve point. Some key takeaways. Fight hard early if you think you can win. Use large-scale social distancing when infection rates are high. In anticipation of using STTQ in the future pushes for reducing infections up front. The slow growth scenario, limiting the strain on the healthcare system, likely calls for a mixed strategy of large-scale social distancing and STTQ among the less vulnerable. And as we point out here, you can see the details in the paper. I'm not going to take up any more time. I'll stop there so we can have some questions.
Thank you very much, Bob. And I wonder if people want to ask questions, they can certainly type them in the chat. I think both discussion kind of complement each other. It seems a lot can be learned by, what happened past 3 years, and it would be a pity if, regulators and scientists and others, and especially, governments lost the opportunity to learn and to reflect upon, ways to improve the response that happened. I think the evidence for economists is very stark, and I don't know. So I have a question here for both of you. I think I can kick off. We have a few minutes. I would let's target 10 minutes more Q&A, since we went a little bit overboard with the presentation. So let's plan to close it like 1:25, let's say, Eastern time, if you don't mind staying over a few minutes. So the question is, how much do you think, this is a question for Bob, but also for Marc, who works with, with the government here. How much of this reforms and this thought should be embedded in, institutionalized? I mean, have you seen the appetite for that? Do you think it's possible to start embedding, for example, some of these restrictions on public financing of golf rock and, in budgets, or this big resistance? And how much, Bob, do you think, there's been a really, post-mortem on what happened in lockdowns? I mean, you have the experience of the US. I hear from Europe, there's a lot of, soul searching and, sort of mea culpa on lockdowns. But in terms of commitment to, really set down some rules of what should be done and not done, or like a lexicography, I don't hear much of that. And then maybe starting with Marc, also in reaction to what Bob said in terms of deaths, excess deaths, if you have any thoughts on that, and what can be done in terms of embedding this in policy.
Sure, thank you. I mean, I think what's clear is that anything that can be done that costs billions to reduce the probability or the impact of a pandemic pays off by saving trillions potentially. And warp speed was in the around 100 billion order of magnitude, and as a good example of that. But many public health actions, including robust surveillance, are not in the 100 billion, they're in the billions or hundreds of millions, and would provide incredibly high returns. Of course, you do it for many years and you get the returns when the event happens. So there's a factor of 50 there, but there's not a factor of 1,000. So I think that's the clearest lesson to me. And just to take some of the specifics of what Bob said, one thing we now know that none of us knew when Bob did that work, or when we did our work early in the pandemic modeling potential futures, was that immunity is not very good. And it's partial, but it doesn't completely protect you. So having the systems in place to learn that early, so that you don't rely on population immunity as your main strategy, would be exceedingly valuable. Likewise, the ability to do testing and tracing in most places in the United States was just not there for social and organizational reasons. In some European countries, it was more there, and in some other countries, it was even more there. But once it gets out of hand, as we allowed it to do in the United States, test and trace was just not an option. So early interventions to keep cases at levels where test and trace can work are complementary, as Bob pointed out. And then I think the last thing is, yes, it was clear to some people that early that children were much less affected, and we wrote several articles making that argument. But the data were complex and contradictory. Really good surveillance systems would have helped to solidify and clarify that in more people's minds. And then investments in things like school ventilation that would allow schools to reopen safely and at the same time pay benefits in health year in and year out are clear ways forward. So I think there's a lot to be done to learn these lessons and put in place the ability to do better public health and the ability to make our activities safer, particularly indoor air as a good example of that.
Bob, do you have any reaction to my questions?
Just to put it into context, one of the things that Marc just said, if we thought of a trace and quarantine kind, or test, trace, and quarantine kind of policy, we calculated that if suppose it costs $100 per test, and you did tests monthly for 10% of the population, that has a cost of about $40 billion per year. The cost of a lockdown, Casey estimated in some other work, is about $20 billion per day. So the cost of a widespread test and trace and quarantine policy would be about 2 days worth of lockdown. So one of the things I think we learned, one of the many things I think we learned from this pandemic, is that some policies are going to be much more productive than others, and the costs of these policies are really quite many of these policies are really quite minuscule compared to the benefits. You asked about other types of policies that you could learn from. One of the biggest constraints we had was the overcrowding of ICUs during the peaks of the pandemic. And if these types of events are likely to come along in the future, it behooves us to build more capacity, the kind of excess capacity you'd have typically, but it's going to be highly valuable at certain periods of time. I think we learned that, to come back to kids, I think we learned that, at least for this virus, they were much less vulnerable. And it might be that parents themselves didn't really realize the human capital consequences. And when things are going on here and you've got a virus that you don't fully understand, you can't blame people for wanting to isolate their children. But the total amount of isolating that we did turned out to be incredibly costly, in my view.
Yes. There's a question here which I think is interesting by John Eklund, and it's what lessons are drawn from different approaches taken across countries. Did any other countries do better than the US? I think here that there are various notable exceptions. One being an advanced economy that went the other way, Sweden, and they certainly did a targeting of the elderly. I mean, they made recommendations. There weren't lockdowns, or I don't know what type of force was applied legally to this. And then there was countries that, for example, I'm Italian, and I know you couldn't leave your house for months, and if you did and found, even walking in a park, you'd be fined like 4,000 or 5,000 euros and arrested and all that, or the like. So, but now if you look at excess mortality, you see that Sweden is the lowest, I think, in Europe, if I'm not wrong, in the cumulative sense, and Italy is one of the highest. So that was all, observationally wrong, both in terms of costs and lives. So what's your reaction to John's question, Bob and Marc?
I'll talk a little bit. I've done a bunch of work on the welfare state in Sweden and policies in Sweden in the now distant past. And one of the things that you have to keep in mind about Sweden, and their excess deaths would be due to a myriad of policies, not just that they let the disease go more than we did or had fewer lockdowns. That, it's a country of 8 or 9 million people, which is about the size of Cook County. And they are incredibly, at least to an American, socially and politically cohesive. So they're able to do policy changes to their social or their retirement benefit system and stuff that would be impossible to do in the United States. So I think in a lot of cases, those policies, if we could implement them, would have been more useful for us. And maybe we learn from them from this pandemic, um, and maybe we don't. At the beginning of the pandemic, Iceland, and I think Marc will know much more about this than I do, was very focused on STTQ, and they kept the infection rate very low for a long period of time. But they couldn't keep it at bay for forever. Now, I don't know how many excess deaths they had relative to us, but I for one was extremely optimistic about Iceland at the beginning of the pandemic.
Yeah, I think Bob makes good points, and I think it became clear that some people used Sweden as a stand-in for a let it rip and protect the elderly approach, and I don't know enough about what Sweden did to evaluate that, but it became quite clear in the United States that when it was ripping, the elderly got hit no matter how much we tried to protect them, and that nobody in the United States came up with a reasonable approach to what some largely on the right were calling for sort of targeted protection and herd immunity for the rest of us. It wasn't possible because when you had external transmission, the nursing homes and the elderly more generally got hit, and they were the ones who died. So I think Sweden is one question, and what Sweden came to stand for in some people's minds is a different question. I put in the chat the book that came out in about a month ago that I was one of about 30 authors of, although Philip Zelikow was the main writer of it, that includes some cross-country comparisons. And certainly one way in which we were outliers in the United States was that we closed schools for about twice as long as many of our peer countries. So lockdown has many different meanings, and Bob highlighted the particular value of lost education, and we were champions in that in the wrong direction. And part of that was an inability to find both the technical means and the courage to open schools, reopen schools in a safe fashion. The last thing I would say, since you're the IMF, is I think there's an important aspect of kind of industrial policy that played a role, and that's highlighted in the early chapters of the lessons from the COVID war book that I put in the chat, which is that the United States, apart from warp speed, which was a very specific type of effort, did not have anything in place with test manufacturers or with other industrial partners to ensure that we could scale up production of PPE tests and other things in a effective way. Whereas South Korea, for example, had learned lessons from its MERS experience, where they had several outbreaks of Middle East respiratory syndrome and other coronavirus, that taught them the value of quick scale up of countermeasures. They also had more effective contact tracing and other things, but the industrial policy aspect of it, I think, is important in the sense that governments need to find ways to partner with the private sector to respond more rapidly and in an organized fashion rather than a competitive fashion.
I have a question for Marc.
Go ahead.
And that is, I mean, you talked about, the possibility of banning such research, but I didn't hear you talk about the feasibility of doing that even if you wanted to. Whereas, because, governments don't cooperate with each other, and so some sort of game theory aspect to it, the countries that are going to do bioweapons research, whether they're open about it or not. And if they do it, then don't others have to do it to try to understand what the consequences might be and how they react? So you
I think that's
can't keep the genie in the bottle.
I think that's a fair question. I think there's a distinction between bioweapons research, which is a concern and which we don't do, and a few countries do, and scientific research that's done in the open that claims to be improving our pandemic preparedness, but is not actually making good bioweapons. I mean, I think most people agree that enhanced flu or enhanced coronavirus is not a good bioweapon, in part because it's very hard to limit who it affects, unless you also develop the countermeasures, and flu vaccines particularly are notoriously hard to develop. So I don't think this is bioweapons research. I think it's a different category of research. Now, there are some game theoretic questions. I agree. I think in terms of limitations on scientific research that is meant for science as opposed to meant for weapons, there are a couple of aspects. The incentive system right now is to publish in Science, Nature, and Cell, and much to a lesser degree in other journals. So I think that leadership by a few powers will change the perception of prestige, could change the perception of prestige, and already has begun to, I think, just due to uncertainty about what this kind of work, how this will be perceived. And the journals can help to enforce that if they choose to, by requiring biosafety assurances in the same way that they require human subjects assurances. So I think there are incentive issues. I don't think that, I mean, if I'm right about the actual benefits of these being small compared to other work, then the incentives are mainly academic incentives rather than national security incentives. There is a category of work where there is some commercial value. For example, making a measles virus that can escape immunity from vaccines is commercially interesting because of the possibility of oncolytic therapy, where you infect cancer cells with virus to kill them. And you can't do that if people have antibodies to that virus. So there are some examples where there might be an economic incentive, but I think actually that's a pretty small subset, and a lot of this is science for science sake, with the unusual unusual property of having a high risk to the globe.
I need to, I think, close here because we are past the time, but I think this was super interesting. We have a few more questions in the chat. I'll send them around to you, Mark and Bob, and so you can, if you wish and have time, get back to those who asked. And I think this was at least for me, extremely educational. These are topics that the fund almost treats as exogenous, but in all truth, the low probability, high risk events of this kind interest us all, and of course we do work a lot in structural reforms. The IEO last evaluation was on the pandemic response, so it's very much, I think, on our table. And I think this seminar has helped us, connect some dots, and we're very glad to have had you, and for your time, availability, and clarity in explaining these matters. So thanks to all, and we hope to see you soon. Mark and Bob's slides will be posted tomorrow alongside the recording of this seminar. Thank you so much. See you all. Thank you again. Have a great day.
Thank you.
Goodbye to all.